Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today, we have an important topic about cervical cerclage guidelines. Okay, so what are the objectives? To know what about the Green Top Guideline by RCOG, February 2022, about cervical cerclage. Okay, all of us know cervical cerclage is used to avoid the risk of preterm labor, and we have two operations done transvaginally. One of them is called McDonald Cerclage, as is in this picture, and the other one is called Cervical Cerclage. Okay, while another one done abdominally is called abdominal cerclage. Okay, the cervical cerclage, McDonald or Cervical, the suture is removed late in pregnancy, and it is done transvaginally, as I said before, and the removal of stitch transvaginally also, while abdominal cerclage can be done before conception or early during pregnancy in some circumstances, but usually it is done before, okay, before conception, and the suture is persistent because the patient should be delivered by cesarean section, and the suture should be persistent. You can leave it in most of cases, okay? While in the transvaginal cerclage, it is removed before labor, okay? Let us go to the guidelines. Let us start with history indicated cerclage. Okay, according to history, is cerclage is indicated? Yes. Women with single tomb pregnancy and 3 or more previous preterm birth should be offered a history indicated cervical cerclage. So, if you have a woman with a previous history in her obstetric history of 3 or more preterm birth, you should offer her cervical cerclage, and this is grade B recommendation. Okay, what about if she has one preterm birth or one spontaneous second trimester miscarriage? Okay, should I do cerclage or not? Really, if she has one preterm birth or second trimester miscarriage, you should do follow up with ultrasound. What's called serial sonographic surveillance, as those who experience cervical shortening may benefit from ultrasound-indicated cerclage. What is the short cervix? If less than 25 millimeter. So, women with history of one preterm labor, I'll do follow-up with ultrasound. If I found the cervix is short means less than 25 millimeter, I can do cervical cerclage, and this is called ultrasound indicated. Okay, this is grade B recommendation. Okay, what about also ultrasound indicated cerclage for women with single tomb pregnancy and no other risk factor for preterm birth? Insertion of cervical cerclage is not recommended in women who have an incidentally identified short cervix on a late second trimester ultrasound scan, and this is grade B recommendation. What does it mean? If you have a case with single tomb pregnancy and she has no risk for preterm birth, okay, while you are doing ultrasound in late second trimester, we discovered short cervix. What you are going to do? The recommendation is not to do cerclage if incidentally discovered short cervix, because there is no risk of preterm labor. She has no risk of preterm birth. So here we are going not to do cervical cerclage, although there is short cervix, but the woman has no history of preterm birth and has no risk factors, other risk factor, so we are not going to do cerclage. Okay, this is grade B recommendation. What about transvaginal cerclage? I said before that we have two operations, McDonald and Schroeder. Okay, Schroeder operation high is called also high cervical cerclage. There is bladder mobilization in Schroeder operation or high cervical cerclage. I should dissect the bladder up to do high insertion of cerclage. Okay, while McDonald cerclage is little lower down. Okay, so which to choose? Which is preferred? I can do both, and it is up to the surgeon. The obstetrician who will do the surgery has the decision to do McDonald or Schroeder, the high or low insertion cerclage. Okay, so that this is decision of the obstetrician according to the situation and which is preferred to him. Okay, however, you should know that when you do cerclage higher as possible, this is practically important and more efficient. Okay, and this is grade C recommendation. What about transabdominal cerclage? In women with previous unsuccessful transvaginal cerclage, insertion of transabdominal cerclage may be discussed and considered. So, we are not going to think about transabdominal cerclage except after failure of transcervical cerclage. Okay? So, we are going to discuss the transabdominal cerclage with the woman and can be considered as an efficient alternative to transcervical if it is failed. Okay? This is grade D recommendation. What about emergency cerclage? In women with a single tube pregnancy, insertion of emergency cerclage may delay birth by an average of 34 days. Imagine. So, emergency cerclage means what? You are doing the cerclage at any time. Usually, we are in cervical cerclage in McDonald and Schroeder, we are doing it at 12, 13, or 14 weeks gestational age. But in emergency cerclage, I can do it at any time during pregnancy to delay the birth, the preterm labor, to avoid the preterm labor. Okay? So, it was proved that this emergency cerclage can delay up to 34 days. Not only that, but also associated with twofold reduction in the chance of birth before 34 weeks of gestation. Okay? However, there are only limited data to support associated improvement in neonatal mortality or morbidity. And this is grade B recommendation. Okay, what about if I found the case with cervical dilatation more than 4 centimeters? Should I do the emergency cerclage or not? No. If you found the cervix dilated more than 4 centimeters or membrane prolapse beyond the external os, this is associated with high chance of cerclage failure. So it is not recommended or not usually done because it is associated with high chance of cerclage failure. This is grade D recommendation. Okay, what about contraindication to cerclage insertion? Active preterm labor, clinical evidence of chorioamnionitis, never to do cerclage infection, continuing vaginal bleeding, BBROM, evidence of fetal compromise, lethal fetal defect, and fetal death. And this is good practice point. What about preoperative management? Okay, women should be offered first trimester ultrasound scan and screening for aneuploidy before the insertion of history-indicated suture to ensure both viability, single tomb pregnancy, and the absence of lethal and major fetal anomaly. This is very important. Okay, this is good practice point. Okay, what else in pre-operative management? Before ultrasound indicated or emergency cerclage, it is preferable to ensure an anomaly scan has been performed. Okay, so you are going to do ultrasound to discover any anomaly in case of emergency cerclage or ultrasound indicated cerclage, and this is good practice point. What about genital tract screening for infection? Is any woman should be screened for genital tract infection before doing cervical cerclage? No. Routine genital tract screening for infection shouldn't be undertaken before cerclage insertion. This is a good practice point. So don't do screening for infection without need. But of course, if you have a symptoms of infection and discharge, you may need also to take swab, culture, and sensitivity test, and so on to diagnose and treat. But asymptomatic women, you are going to do screening for genital tract infection because you are going to do cerclage? No, this is not routinely done. Okay, and this is a good practice point. Should I give the patient tocolysis before doing cerclage or after cerclage? There is no evidence to support the use of routine perioperative tocolysis in women undergoing insertion of cerclage, and this should be considered on an individualized basis. So it depends on the case situation and the circumstances. Okay, so this is the decision of the obstetrician. This is good practice point. Okay, what about perioperative antibiotics? To give or not to give? The decision for antibiotic prophylaxis at the time of cerclage placement should be at the discretion of the operating team. This is the decision of the operating team according to the circumstances and the situation. So discretion means this is the opinion of obstetrician doing the follow-up for the case. Okay, so this is grade C recommendation. What about use of progesterone supplementation following cerclage? Routine use of progesterone supplementation following cerclage is not recommended, and this is a good practice point. What about anesthesia? Both general and regional anesthesia are safe. Okay, so the choice of anesthesia should be made by the operating team in conjunction with the woman, and this is grade B recommendation. Okay, let us go to cerclage as a day case procedure. We have a day case procedure and hospital admission for 48 hours. There were clinical trials about the comparison between both. Which is better? Okay, both of them equal, by the way. Both of them equal. Okay, what about the choice of suture material and the technique? This choice of suture material should be at the discretion of the surgeon, according to the circumstances. But you should know that non-absorbable suture should be used. Non-absorbable suture should be used. Okay? And this is good practice point. What else in a choice of suture material and technique? Is there any difference by using two purse string suture and one single suture? There is no difference. Okay? And they should be at the discretion of the surgeon. So, the opinion is the opinion of the obstetrician to do either two purse string suture or single suture. And this is grade B recommendation. Okay, what about cervical occlusion suture in addition to primary cerclage? Is it routinely recommended? No, is not routinely recommended. And this is grade C recommendation. Okay, what about which is better, or using high insertion cerclage like Cerclage or low insertion cerclage like Magdalene? Both of them can be done. Okay, however, Cerclage needs bladder mobilization, need more skills. Okay, but both of them can be done. But in general, we said before, cerclage should be placed as high as is practically possible. Okay, and this is grade C recommendation. What about, should you encourage the woman to bed rest after cerclage? Really, bed rest in women who have undergone cerclage shouldn't be routinely recommended, but should be individualized. Okay, so you know, if there is risk of preterm labor, if there is pain, if there is other risk factors, maybe different cases. So it will be individualized. The decision will be individualized. But routine bed rest is not recommended. Okay? And this is good practice point. Sexual intercourse after cerclage. Is it prohibited? Should you prevent the woman from intercourse after cerclage or not? Abstinence from sexual intercourse following cerclage insertion shouldn't be routinely recommended. So, it is not routinely recommended. Okay? This is good practice point. What about rule of post-cerclage serial sonographic surveillance of cervical length? Should I do ultrasound follow-up for cervical length after cerclage? It is not recommended, really. Okay? But it may be useful in individual cases following ultrasound-indicated cerclage to offer timely administration of steroid. So, in certain cases, so it is not, as I said before, it is not routinely recommended, and this is grade D recommendation, okay? The serial ultrasound after circulation. But in certain situations, in individual cases, with ultrasound-indicated cerclage who has short cervix, you may need, and risk of preterm labor, you may need to do serial ultrasound in such cases. Why? Because I may need to give the patient antenatal corticosteroid to enhance fetal lung maturity at proper time. Okay? So, this is the decision as regard the post-cerclage serial sonographic surveillance. And this is grade D recommendation. What about fetal fibronectin testing? We know that we are using fetal fibronectin testing for prediction of preterm labor and so on. Is it needed after insertion of cervical cerclage? Really, it is not recommended post-cerclage. However, the high negative predictive value of fetal fibronectin testing for subsequent birth at less than 30 weeks of gestation in asymptomatic high-risk women with a cerclage in place may provide reassurance to women and the clinicians in individual cases. So it is not routinely done, fibronectin testing, but in certain situations, in high-risk patients, okay, asymptomatic, less than 30 weeks gestation, to reassure the woman, okay, you can do it. So if it is done, individualized according to the circumstance, as I said. Okay, what about Arabin pessary or progesterone instead of cerclage? Can Arabin pessary, as in this picture, could be an alternative to cerclage? This is Arabin pessary. It is silicone. It is made of silicone and flexible and perforated one, as you see, to allow for cervical discharge. Okay. Is Arabin pessary can be an alternative to cerclage? Also, can progesterone supplementation be an alternative to cerclage? Really, there is no evidence that either progesterone or Arabin pessary alone are more or less effective than cervical cerclage. So up to now, we don't know which is better. Is it more or less effective than cervical cerclage? Okay, and this is grade C recommendation. Let us go to cervical cerclage removal. Okay, as regards the transvaginal cerclage, whatever McDonald or Schroeder, usually removed between 36 weeks plus 1 day gestation and 37 weeks gestation. Unless birth is by pre-labor cesarean section, in which case suture removal could be delayed until this time. Okay, so who are going to be delivered vaginally? You should remove it between 36 and 37 gestational age week pregnancy. Okay, but who are going to do elective cesarean section? You can remove it at the time of cesarean section. Okay, and this is good practice point. What about women presented to you with established preterm labor and cerclage? Okay, should be removed. The cerclage should be removed to minimize potential trauma to the cervix. May cause hazardous and very dangerous cervical tears. So, if the patient presented to you in labor and you know that she did before cervical cerclage, you should remove it immediately to avoid trauma to the cervix. And this is a good practice point. Okay, what about if the patient did a high cervical cerclage like Schroeder, which is inserted with bladder mobilization and dissection, as I said before? This category usually require anesthesia for removal. To find the suture and to cut it properly and remove it, you will need anesthesia, and this is great, good practice point. Okay. What about women with transabdominal cerclage? This category of women require birth by cesarean section, should be delivered by cesarean section, and the abdominal suture may be left in place following birth. Okay, so there is no vaginal delivery in abdominal circulation. will be by elective cesarean section, and the abdominal suture may be left in place following birth. Okay, and this is good practice point. What about if we have a case with cervical cerclage and BBROM? BBROM means pre-labor, preterm rupture of membrane. Okay. Okay. Delayed suture removal until labor ensues, labor follow or develop, or birth is indicated, is associated with an increased risk of maternal and fetal sepsis and is not recommended. So, delayed suture removal until labor go on or happen. This delay may cause maternal and fetal infection like chorioamnionitis, and this is very dangerous. So it is not recommended. This delay is not recommended. You should remove the suture. Okay? Okay. What about if woman with BBROM between 24 and 34 weeks of gestation and without evidence of infection or preterm labor? Can I delay removal of cerclage for 48 hours? It can be considered in some cases. For what? For only one reason: in utero transfer. To transfer the woman from one hospital to the other with more maternal care and more neonatal care. So, yes, you can delay it until you transfer the woman for more care for her and for baby later on. Okay? So, this is called good practice point, but the pregnancy should be between 24 and 34 weeks. What if BBROM happened before 24 weeks or after 34 weeks of gestation? Given the risk of neonatal and the maternal sepsis and the minimal benefit of 48 hours of latency in pregnancy with BBROM before 23 and after 34 weeks of gestation, delayed suture removal is unlikely to be advantageous in this situation. So, don't delay removal of a stitch if before 24 weeks or more than 34 weeks gestational age, and this is grade C recommendation. This is the end of my lecture. I hope it was beneficial for you. This is my books published on Amazon: Textbook of Obstetrics, Textbook of Gynecology, Contraception Handbook, and the Multiple Choice Question Book. And this is the last one, Medical Disorder in Pregnancy. You can find them all at my site on Amazon. Okay, and this is my site on YouTube, and this is my site on Blogspot. Thank you, everybody, and my best wishes for all of you.